It is my pleasure now to introduce the next plenary speaker, Dr. Ernest Hawk. Dr. Hawk will talk to us about cancer preventive agents. Ernest Hawk, MD, MPH, is Vice President and Division Head of Cancer Prevention and Population Sciences at the University of Texas MD Anderson Cancer Center and holds the T. Boone Pickens Distinguished Chair for Early Prevention of Cancer. Additional responsibilities include leadership of the Duncan Family Institute and MD Anderson's Cancer Prevention and Control Platform that plans, implements, and evaluates evidence-based actions in public policy, professional and public education, and community-based service delivery to reduce cancer and related risk factors at the population level. He earned his medical degree from Wayne State University and his MPH from Johns Hopkins University. Dr. Hawk's presentation is entitled Aspirin as a Cancer Preventive Agent, Existing Evidence and Remaining Questions. Dr. Hawk, welcome. Thanks very much for being here today under these trying circumstances, and are very looking forward to your presentation.
Thank you very much. Good morning. It's a great pleasure to be with you. I usually speak to either public groups or to colleagues working in various aspects of cancer, from prevention all the way out to treatment and survivorship. So this is a bit different for me and probably a bit different for you. Rather than speaking of the most novel technology, I've got a presentation focused on the use of aspirin, but not for cardiovascular risk reduction as is currently indicated, but rather as an emerging indication for cancer prevention. When I entered this field, I'm a medical oncologist by background, but most of my professional career has been devoted to the identification and development of cancer preventive agents, and perhaps the best known example of that is something like the HPV vaccine that now can thwart the development of not only cervical cancer, but the 5 or 6 other cancers that are driven by HPV infections. However, about 25 years ago, trying to put the words cancer and prevention in the same sentence was really an oxymoron. We've come a long way since then, as I'll summarize for you in this very quick presentation. I will note that I'm trying to summarize more than 200 studies that have been done around the use of aspirin and non-steroidal anti-inflammatory drugs in cancer prevention, and so this is very much a high-level overview attempting to summarize that body of literature, as well as to outline some of the most compelling questions that remain. This is my disclosure. Nothing here relates to the presentation today. So the first message is that indeed cancer is a preventable disease. Just as cardiovascular events or chronic inflammatory conditions are preventable, so cancer we now know to be preventable. And in Western populations such as the United States, it's estimated that anywhere between 1/3 to 1/2 of cancers are preventable. However, doing that is a huge challenge. Outlined here are the various risk factors that relate to cancer development and those that are approachable by preventive strategies. However, for effective prevention to occur, it needs to operate both at the individual level, typically delivered in something like a clinic focused on cancer prevention, such as we have at Anderson, or complementing that at the population level with things that are safe and effective enough. There are 8 domains of action that are required on a personal basis. They're outlined here. Understanding family history is essential because that insight can modify individual risk such that screening tests, for example, should be offered earlier or with more invasive testing. So that's the start. Second, eliminating all tobacco exposure, both direct as well as indirect, eating a healthy diet, and maintaining a healthy weight across the lifespan by engaging in physical activity. Reducing UV exposure or limiting UV exposure, in particular both sun as well as artificial UV exposure. And then finally, following recommended screening tests, there are now at least 4 that are recommended for average risk populations and more that can be recommended to reduce cancer mortality for high-risk populations. And then finally, the use of preventive medications and approaches where they're shown to be evidence-based, and that'll be the topic of today's presentation. Complementing then those personal actions at a population level, is action through public policy, public and professional education to stimulate foundational understanding, as well as delivery of community-based, evidence-based clinical services to the population at large. And that's where, in the United States and many other countries, we have the greatest challenge, because the key is to try to reach the less fortunate, underserved sectors of the population with those sorts of strategies, and that indeed is a huge challenge. Again, today I'll be speaking about aspirin, one component of those 8 domains. So what's the evidence around aspirin as a cancer preventive agent? Well, it comes from both animal-based mechanistic studies, complemented by strong proof now from both epidemiologic investigations that began in the early to mid-80s against colorectal adenoma development or precancer development, as well as cancer, with demonstrated reductions of both incidence and mortality. Complementing that then, preventive effects that have now been demonstrated both observationally as well as experimentally across other sites, in particular the upper GI tract, and in some cases women's cancers. And then finally, there's now emerging evidence, not yet entirely convincing, that aspirin may be effective in reducing overall cancer incidence and mortality, and possibly all-cause mortality as well. And I'll review each of those in turn. So first of all, I mentioned there are more than 200 studies that have asked and answered critical questions here. This single slide tries to capture those domains that will be the subject in greater detail of the rest of the talk. First of all, through observational study design, both case control as well as cohort studies followed over intervals as long as 15 years, is the first body of evidence, more than 100 studies in that category. The second domain, randomized controlled trials, pitting aspirin against placebo for adenoma recurrence in the colorectum. Third, more than 50 studies that were originally designed for cardiovascular risk reduction. Most of these were placebo-controlled, but not all, that have looked with extended follow-up at cancer outcomes in addition to the original cardiovascular endpoints as the studies were designed. Fourth, evidence coming against cancer incidence directly from long-term follow-up of high-risk cohorts, in this case the CAP2 study based in Europe that enrolled individuals with Lynch syndrome or predisposition to colorectal and uterine cancers, as well as a variety of others in a familial syndrome that have demonstrated long-term incident reductions against colorectal cancer. And then finally, the fifth domain, long-term study out of the Women Health Study based in Harvard, which looked at randomization of 100 milligrams every other day versus placebo. In the extended follow-up now, there seems to be a reduction in cancer incidence among those randomized to aspirin. So now going a little bit more in depth in those 4 or 5 different domains. This slide summarizes the data, these 2 slides, looking at aspirin against placebo in cohorts at increased risk for colorectal cancer due to prior colorectal adenomas. In the first study published by Barron, that looked at 81 milligrams as well as, or the cardiovascular prophylactic dose used in this country, anywhere between 75 to 100 milligrams a day is used in the UK and Europe. But they looked at that dose versus the traditional adult strength aspirin, 325 milligrams given daily over a 3-year interval to some 1,200 patients with prior adenomas. And the major finding out of that study published in the New England Journal was a 20% reduction in adenoma recurrence among those randomized to 81 milligrams. The second study, published about the same time by Sandler, coming out of a large cooperative group here in the country focused on colorectal cancer, looked at traditional adult dose aspirin, 325 milligrams given a day over a 3-year interval, and identified a 35% reduction in recurrent adenomas among those on the aspirin arm compared to those on placebo. So 2 statistically significant, important studies demonstrating a benefit. The third study down then comes from France, a smaller study, but again in individuals at higher risk for colorectal cancer with an adenoma endpoint, did not see a statistically significant reduction, but about a 30% reduction in adenoma recurrence, and in a secondary analysis focused on large adenomas. That's one of the classes that we worry most about because it's closer, we believe, to invasive disease, and 83% reduction. So 3 studies, very strong evidence of reductions in colorectal adenomas with over about a 3 to 4 year interval of treatment. I'm sorry, let me go back. These studies then complemented those earlier. The first from the UK showing a 21% reduction in recurrent adenomas and a 30% reduction in advanced adenomas. Next study down coming from Japan, again placebo-controlled, looking at 100 milligrams per day over a 2-year interval with a 40% reduction identified there. The last 2 studies were in very high-risk individuals with familial tendencies, germline tendencies, saw nothing in the original period of the trial. However, with extended follow-up, the Lynch study there captured in the bottom against placebo showed a 60% reduction after 10 years of follow-up. And that's a major theme that I'll leave you with today. It seems as though duration following aspirin exposure matters. That is, aspirin is not instantaneously effective in reducing colorectal cancer risk. It takes anywhere between 5 to 10 years to see that benefit. It's not absolute, but it is significant, both in clinical as well as statistical terms. Summarizing a large body of observational data here in a single slide, this is showing the consistency across both case control as well as nested case control designs. Included this are very large long-term studies like the Health Professionals Follow-Up Study coming from one of the 2 large Harvard cohorts, as well as the Nurses Health Study, the Women's Health Initiative, which was a nationally representative study. And you can see in sum about a 30% reduction in overall colorectal cancer incidence risk. Now, complementing those observational data, there were detailed data coming out of not a cancer risk background or the general population, but out of those randomized to aspirin versus placebo because of cardiovascular risk reduction. So long-term follow-up out to 20 years from 5 randomized trials was summarized in this analysis by Rothwell, published in The Lancet several years ago, and again showing the same general story, about a 30% reduction in colorectal cancer incidence, as well as a significant reduction in colorectal cancer mortality as well. So a very consistent story, observational as well as experimental, related to colorectal cancer risk and the use of aspirin. Moving then beyond colorectal cancer to all cancer, and this is drawn from the recent meta-analysis published in the Annals of Internal Medicine that led to the recommendation of aspirin as an adjunct to other forms of care for specific populations. I'll share that specific indication later in the presentation. These are the data that led to it. So now looking not at colorectal cancer, but all cancer, you can see this group of analyses based in cardiovascular primary prevention, cardiovascular primary and secondary, including the adenoma trials or the more detailed analyses of Rothwell, a consistent story of anywhere between 5 to as much as perhaps 15-20% reductions in all cancer. Specific to the Rothwell study, where they had detailed data on the cases as they occurred, you can see reductions, some statistically significant, others not, of about a 20% reduction in GI tract cancers, a 50% reduction in female reproductive cancers, so predominantly uterine and ovarian, as well as perhaps 20% reduction in cancers of the respiratory tract. Again, these from randomized trials, but originally premised for cardiovascular disease for the most part. Complementing those data around all cancer came the question as to whether aspirin may be useful as a therapeutic adjuvant. And this is one of the earliest studies that looked at that question, not of aspirin per se, but of anti-inflammatory interventions. And this study, published in Cancer Research back in 1994, took one population of patients with a variety of different tumors, advanced in stage, and the question here was whether anti-inflammatories could palliate or improve the lives, maintaining weight, decreasing pain, improving symptomatology for patients who had been diagnosed with late-stage cancer. And much to the surprise of the investigators, indeed they saw that their symptoms were improved with either prednisolone or a corticosteroid administration or indomethacin, a popular non-steroidal anti-inflammatory at the time. But complementing that symptomatic outcome was also an improvement in overall survival. And this is showing about doubling of the survival rates of those randomized to indomethacin versus placebo. This at the time was a very unexpected finding. Aspirin and aspirin-like drugs were being used for palliation, but it was not known that there might be a survival benefit. Well, subsequently, that question has been asked and answered by a number of other observational studies as well as randomized trials. This is summarizing the trial data, again, predominantly built out of a cardiovascular risk background. But what it demonstrates are significant reductions in the second and down studies of anywhere between 5% to as much perhaps as a 20%, in one study a 34% reduction in cancer mortality, broadly spoken, with the use of aspirin versus placebo. Some of this, again, recapitulates the story that the follow-up time and daily dosing is particularly important. At the bottom of the study are, again, the detailed analyses of Rothwell et al. Drawing upon those 5 large studies of cardiovascular risk with collection of specific cancer data. And again, you can see very substantial reductions in pancreatic cancer mortality, colon cancer mortality, GI cancer mortality, as well as that of specific histologic subtypes of cancer. But importantly, all showing up after 5 years of administration and follow-up. So that got us, before that, it got us thinking at the National Cancer Institute, where I worked at the time, whether indeed aspirin, effective against cardiovascular events and possibly against cancer, at this point in animal models, not yet with the wealth of data that I've shared with you, but I and some of my colleagues asked the question whether in a nationally representative study such as the NHANES study, we might be able to see effects not against cancer mortality or cardiovascular mortality, but all-cause mortality. And this is the first study published again many years ago now, 2004, which showed indeed reductions of, I can't make it out from here, and that's cut off, but somewhere on the order of 8 to 10% reductions in overall mortality, and individuals observationally using aspirin as opposed to not. So not a randomized trial, observational data from a nationally representative cohort study, and an analysis conducted within that, but again suggesting the possibility that aspirin in older Americans may be useful for reducing overall mortality. Of course, all of these observational analyses can be challenging for a whole variety of reasons, differences in patient populations, the specific intervention, dose, frequency, duration, particularly duration of follow-up being a very important variable, as you can see in the data I've already presented to you. But following up on that question as to whether aspirin may indeed reduce all-cause mortality in a Western population are these data. And again, there's some heterogeneity, but generally 5 to 10% reductions in overall mortality, particularly with extended daily dosing from several different lines of research. Now, the story is not all positive, of course. Aspirin, like any medication, has important side effects, and this tries to capture most of the important ones that are important for clinical decision-making for the patient before you. The most commonly reported adverse effects of course, relate to the upper GI tract with abdominal pain, dyspepsia, nausea, vomiting. But the more important or serious adverse events are related to bleeding, either in the GI tract, which in these analyses, again, summarized against the world's body of literature available at the time when this was put together, about a 60% relative increase as opposed to those not using aspirin for GI bleeding, serious GI bleeding, absolute event rate of about 3 per 10,000 patient years, and similarly a lower risk but nevertheless substantial for intracranial bleeding as well, about a 30% relative increased risk or 1 event per 10,000 patient years of aspirin exposure. A very important facet of that risk data, however, is the fact that it tends to increase at advanced ages, and this estimates, again, a 5% increase in incidence rate for hospitalization associated with bleeding per year of age. And then the bottom data there summarized from one of the large trials suggesting a dose responsiveness to these risks as well, which is seen in the broader literature also. So, putting all of that data together, for several cycles now, the U.S. Preventive Services Task Force, who are charged with making general, broad clinical recommendations to the average risk general population, largely composed of general internists, pediatricians, as well as family medicine physicians, came out in 2016 for the first time with a recommendation for aspirin around both cardiovascular risk, but included phraseology around reductions in colon cancer risk for individuals between the ages of 50 to 70. For younger individuals, no recommendation could be offered because of inadequate evidence, and for individuals older than 70. And between 50 and 70, very important need to balance on an individual level the potential benefits of aspirin versus the risks, because again, this is very good news, but it comes at a risk, particularly for older individuals or those susceptible to GI bleeding. The mechanism that underlies these various associations is extremely complex. This single figure from a recent review in Nature Reviews Cancer, one of the most authoritative summaries of this body of literature, highlights at least 4 domains of action. The predominant ones are around prostaglandin endoperoxide synthase, or COX, or cyclooxygenase enzymes, shown there in the bottom left and the top right, effects against COX-2 and COX-1, which are the most established mechanisms with a variety of downstream impacts on cellular proliferation, survival, apoptosis, as well as cell growth. However, aspirin seems also to have effects more directly on beta-catenin signaling, which is important for colorectal cancer as well as a variety of other cancers, as well as on the immune system in ways that are still being understood. So there is real biologic plausibility around these associations that have been identified observationally in randomized controlled trials. The last part of the talk, I just wanted to highlight that there's a lot of work now. We have those general recommendations for adults between 50 and 70 that are made based upon cardiovascular risk predominantly, but with an ancillary benefit of reductions in at least colorectal cancer incidence. However, now there's an attempt to try to advance precision medicine, or who should and who should not be given the option of aspirin or nonsteroidal anti-inflammatory therapy for this indication. And there are a variety of strategies that have been publicized. I'll highlight 2 for you from SNP analyses, GWAS analyses, that have found important associations. This summarizing a locus at RS 2965667, which is the dominant genotype is the TT genotype for individuals carrying an A allele at this locus, either in a heterozygous or homozygous configuration, don't see the benefit of aspirin therapy, but rather see an increased risk that is not yet explained mechanistically. The one gene that's been associated with this locus and believed to potentially be playing a role is beta-catenin. So this demonstrates some degree of biologic plausibility behind that association. The big challenge, however, is to replicate that association across populations and in large data sets. Another that has been popularized in the medical literature, this again drawn from that same JAMA paper, is another locus at which the AA genotype, which is most dominant in the population, seems to be associated with a 30 to 40% reduction in risk of colorectal cancer. However, having the C allele nullifies the potential usefulness of aspirin in that population. Fortunately, again, that's a very minor allele in the general population. And once again, with this locus, there is biologic plausibility because IL-16, a critical pro-inflammatory cytokine, is in that vicinity, and so this is believed to be one of the ways that may be true. So what I've outlined for you is aspirin seems to be effective against at least colorectal cancer, possibly upper GI cancers, and a broader array of cancers, if indeed we had large trials to be able to see those benefits, as well as the well-established role in cardiovascular risk reduction. So it raises the question as to whether there are adverse interactions or indeed underlying mechanisms that both cancer as well as cardiovascular disease may share. And this just outlines a few that are commonly discussed in the literature, and the fact that aspirin may very well inhibit aspects of both of those, thus leading to the reductions in both cardiovascular risk as well as cancer that have been identified. One of the major questions going forward is how we can build upon these data to affect reductions in broader segments of the population. Aspirin has its advantage, a very old drug, a very cheap drug, very easy to use, and with relatively unusual side effects. So a number of companies as well as investigators are interested in investigating the idea of polypills. These have been routinely used in some areas of the world, particularly combating drug-resistant infections. A polypill now has been developed, several different forms of them. One of them has been approved for use in Latin America, reducing risk of cardiovascular disease, and another has been approved in Europe, not yet one approved in the US to my understanding. The potential benefits are outlined there. The simplicity, obviously, of the intervention and the ability to streamline both upstream and downstream delivery and use of that sort of strategy, making it a highly scalable and potentially useful intervention. However, the barriers to use predominantly for drug development in the interests of a company such as or a clinician, the limited autonomy of being able to adjust doses when needed for management of side effects, for example, as well as uncertainties with regard to regulatory agencies and how they might view such combos, particularly by the FDA in the United States. I want to end on two slides that summarize the questions and challenges that remain. So this is drawn from clinicaltrials.gov a little while ago, and it summarizes the major questions that are being asked in the field of cardiovascular disease prevention. And here you will see a variety of different conditions, all above average risk. So looking at individuals with diabetes, high baseline cardiovascular risk based on something like the AHA risk calculator, or elderly individuals alone without either diabetes or cardiovascular risk factors. The doses that cardiovascular trials are looking at, anywhere between 75 to 100 milligram. Many of these are based in the UK or Europe, where 100 milligram and 75 are more commonly used than the 81 milligrams here in the United States. You'll notice that recruitment is completed for most of these placebo-controlled trials, so we should have data in the very near future. One of the most interesting of these studies is the last one on the list to my eye, because that's really taking elderly individuals and randomizing them to placebo versus aspirin and looking at a whole battery of outcomes that are important to those populations, including cardiovascular events, feelings, things like quality of life and mobility, dementia, as well as cancer incidence. And the last panel I wanted to leave you with, how aspirin is being explored in high-risk cancer populations. So not cardiovascular disease, but cancer. You'll see that most of the studies are focused on populations at risk for colorectal cancer, since that seems to be The place where its efficacy is most clearly been demonstrated to date, but exploring different dosing strategies and dosing combinations, in particular with other agents that are believed to either mitigate the toxicity of aspirin, in the case, for example, of esomeprazole, third on that list, or that might boost the anti-cancer efficacy with something like icosapentaenoic acid or eflornithine, both agents that have, in individual trials, shown to reduce cancer risks. The duration of treatment, again, many of these are biomarker-based and intended to get at questions of mechanism, so they tend to be short. If they're looking at cancer outcomes, they need to be at least 5 to 10 years in duration. Once again, several of these studies have completed accrual, and so we're simply waiting for the results to better inform us as to how we might use aspirin to achieve an overall risk reduction at the population level. With that, I'll thank you very much for your attention and be happy to remain afterward and take any questions there might be. Thank you very much.